Thank you very much. I'm very happy to be here. Do you see this in full screen? It looks good?
Yes.
Okay, perfect.
Yes.
Okay, awesome. Well, I'm very happy to be here today, and I'm going to be speaking about Charcot foot and how to make the diagnosis and avoiding some of the common misdiagnoses. I don't have any financial conflicts. I do have some organizational conflicts. I'm chief of podiatry at the University of Texas Health Science Center in San Antonio. I'm president of the American Board of Podiatric Medicine. I'm here in headquarters giving this speech from Los Angeles. And I'm the associate editor of the Journal of the American Podiatric Medical Association, also fellow faculty in podiatric medicine at the Royal College of Physicians and Surgeons of Glasgow. So a lot of what I'm speaking about is based on the International Joint Task Force that was put together on about 2000, I think it was 2010 that we put it together. We published this in 2011. And these were a group of Charcot foot experts from around the world, met in Paris at the La Salpêtrière Hospital, and came up with which was really the first consensus on the diagnosis and management of the Charcot foot. And we're in the process of redoing this, actually. We're going to be meeting in Paris in about a month to work on this. And so these are both, these manuscripts are both available open access online. So if you just search the Charcot foot and diabetes, or you can send me an email, I'm happy to send it to you. But much of what I'm going to discuss today is already discussed there. So we need to understand that first, Charcot foot is a condition from neuropathy that it takes place in the presence of neuropathy before it leads to this destruction of the bones and the joints. And in the Western world, at least, and now in the I guess the modern world, now the most predominant cause of neuropathy that leads to Charcot foot is diabetes mellitus. However, we do see patients that have alcoholic neuropathy, some still with leprosy that lead to neuropathy and Charcot foot. Tabes dorsalis, I've never seen a case of that, although that's the original description from Charcot himself, leading to the bone and joint condition. We have seen patients with congenital insensitivity to pain, and then also HIV neuropathy. I wrote about one of the first cases of HIV neuropathy leading to Charcot foot. So it's important to have a high index of suspicion when you see somebody with a bone and joint problem that also has neuropathy. So we know that there is a 36 times increased risk for a foot ulceration when you have Charcot foot, 30% incidence of bilateral disease, and a 15% risk of major amputation due to Charcot. The Charcot, looking at mortality, which is interesting, that maybe you wouldn't think about putting these two things together, mortality and Charcot foot. We obviously equate amputation with mortality because of a sedentary lifestyle and the cardiovascular decompensation that occurs after that. However, with Charcot foot itself, it has been shown to increase the mortality rate, possibly due to the increased rate of coronary artery disease because of the medial calcific effect of the bone demineralization in the foot. But, or perhaps even due to inflammation. We're seeing like some of these conditions that's just an inflammatory bomb going off in the body, and it can increase the risk of cardiovascular disease. So Charcot patients have a higher rate of CAD and coronary plaques when compared with patients that just have regular diabetic peripheral neuropathy. The concomitant CAD is an independent predictor of survival in Charcot foot, and the mortality risk is 2.7 times greater in Charcot patients versus matched cohorts. We also know there's a problem with the quality of life in Charcot, that patients have frequently, the condition leads to permanent disability and premature retirement. When we think about the pathogenesis, let's focus on the orange box over here. Patients have, they develop, number one, diabetic neuropathy, and then that leads to an exaggeration in blood flow, that can be caused by minor trauma or foot ulceration or surgical insult or revascularization. When you looked at the diabetes or the Charcot, the CDUK study, the Charcot and Diabetes UK registry that was created, about 250 patients with Charcot foot, around half of them had some type of surgical insult that preceded the Charcot foot. That leads to continued, that can cause fracture or dislocation and then continued insult. There are these deforming forces which lead to the joint dislocations or the fractures. And the major deforming force is the pole of the Achilles tendon. So if you can see in this schematic, here's the Achilles tendon pulling up on the calcaneus, and that is forcing the talus and the calcaneus to be plantar flexed, which increases the pressure at the midfoot, and it dislocates the midfoot during ambulation. So even without an acute or major trauma, the trauma from walking and the deforming forces are leading to this dislocation. It's important to have a high index of suspicion for this. A red, hot, swollen foot is considered Charcot foot until proven otherwise. In any patient with neuropathy, you see a red, hot, swollen foot, it is Charcot foot until proven otherwise. Charcot foot's actually a medical emergency. Now, it may not be an immediate life-threatening emergency, but a medical condition becomes an emergency when there's a therapy available that can transform its natural history. And in this case, we do have therapies available that can transform the natural history of Charcot foot and avoid the dislocation and avoid an amputation or increase in later mortality. How do we most accurately make the diagnosis? I prefer to use temperature as the major tool in looking for inflammation in patients with especially asymmetric inflammation, asymmetric temperature differences. It would clue me into the fact that there is some type of inflammation going on in the foot. It is highly, highly sensitive, not as specific for Charcot. It could be other conditions like gout or DVT or cellulitis, but it is highly sensitive for inflammation going on in the foot. So you can see this is a contact thermometer. So we call this thermometry, and an asymmetric skin temperature difference of 2.5 degrees Celsius is considered significant. However, sometimes a picture is worth more. And in this case, we use something called thermography, where this was the first camera we got, which was kind of like a gun. And this thing was very expensive. It was $15,000. We got it on a grant, and we were able to look at people's feet and see the temperature differences, but get a pictorial view of the temperature differences. Now, these things are much less expensive. In fact, the new camera that I have was only $300. I bought it on Amazon.com, and it hooks up to my iPhone. And I can get pictures like this, and I can see pictorially the difference in the temperature, but I can also show this to my patients and say, look, this is how much your foot is inflamed. And really the patients respond to this very well by seeing the difference. And so here's another patient, and you can see the dislocation. Look at this. This is a total dislocation of the midfoot. The calcaneus and the talus are pointed plantarly. The Achilles tendon is pulling up on the calcaneus. The whole forefoot is dislocated from at the midfoot level, and you can see the temperature change between the feet here, a whole 6 or 7 degrees Fahrenheit. So we need to define the role of imaging. It's always important to confirm the Charcot foot by imaging. X-ray is really most useful. You know, there may be sometimes no findings or subtle findings. I always obtain weight-bearing X-rays and comparisons with either a previous X-ray or bilateral feet. When you actually see fractures or dislocations or rocker bottom deformity, those are late findings in Charcot foot. It's been going on for a long time when you see those. The most important angles to look at is the talo-first metatarsal line and the calcaneal inclination angle on the weight-bearing lateral. And this also can predict ulceration. And if the x-rays are negative, that's when we move to MRI. But look at this, this is the talo-first metatarsal line. In A, you can see the line between the talus, bisecting the talus and bisecting the first metatarsal. It's almost unbroken. You know, it's normal to be unbroken, this line. And then you can see this is the same patient 1 month later after presenting to the emergency department, and they didn't know that it was Charcot foot, had a hot, swollen foot. They continued to walk on this. And now you can see 1 month later, there's a total dislocation of the midfoot, and the calcaneal inclination angle, the angle in white, has greatly reduced. So the calcaneus is almost plantar flexed. MRI is really the most sensitive and specific for Charcot foot. The early findings are pretty clear on MRI: marrow edema, trabecular fractures, periarticular soft tissue injuries. But what's most useful is to understand the secondary signs to look for in an MRI to help distinguish it from osteomyelitis. So what you need to know is that Charcot foot predominantly occurs in the midfoot. It affects multiple bones and joints, and deformity is very common. Osteomyelitis predominates in the forefoot and the rear foot. It generally only affects one bone, and deformity is rare. And there is often direct extension from the skin ulcer directly to the bone in osteomyelitis. So looking at different classifications, this is one that we came up with, which is somewhat based on the UT classification, where you have where you stage and you grade. But the previous classifications were either radiographic, anatomic, active versus inactive. That's what we described in the first Charcot consensus. And then this one is a two-axis classification, where it's based either in the forefoot, midfoot, or rear foot and ankle. That's the anatomic part. And then the stage it's an acute Charcot with no deformity, Charcot with deformity, C, Charcot with deformity and ulceration, or D, Charcot with osteomyelitis. And the more proximal your Charcot gets and the more complicated it gets, the more likely you are to have an amputation. And this was later validated by Vijay Viswanathan and shown the amputation rate definitely increases as you get more proximal and more complicated. So I'll just leave you with some of the common misdiagnoses for Charcot foot, and this I see this all the time out of the emergency department. The emergency departments are not looking for this, and they're seeing patients with these acutely swollen, red, warm feet, and so they're commonly misdiagnosed as a DVT initially, cellulitis sometimes, gout frequently, and then also osteomyelitis. Now, cellulitis and osteomyelitis, it's rare. Well, osteomyelitis, extremely rare. If you've never had an ulceration and it's a diabetic foot osteomyelitis, that would be nearly, something to really not even think about. Cellulitis, there definitely needs to be some type of break in the skin. And if you don't have an ulcer, that's also unlikely. DVT can be ruled out with either D-dimer, although that might be somewhat inflammatory, and you could have a high D-dimer even in patients with Charcot foot, but also with a duplex. And then gout, really looking at the patient's history and other things to rule out gout. So here's the University Hospital there in San Antonio. It's actually the 7th largest hospital in the country, and that's where we do most of our work. So I thank you very much for your attention, and thank you for letting me go a few minutes early.